Welcome, deep divers. Today, we're putting on our detective hats, you could say. We're embarking on a pretty fascinating journey deep inside, well, the human brain, one of the most complex things in the universe, really, our mission. It's all about uncovering the critical clues, the signs that help doctors figure out exactly where brain injuries have occurred. We're going to be navigating the brain's intricate landscape by looking at something called cortical and subcortical lesions. So the goal is to pull out the key info about these specific injuries, understand the symptoms they cause, which can be really diverse, and learn how professionals pinpoint their location. Get ready for some, honestly, quite surprising facts and maybe a whole new appreciation for how your own mind is put together.
Absolutely. The brain is just unbelievably complex. It's this delicate balance, all these interconnected regions, each doing its own vital job. And understanding these lesions, cortical and subcortical, it's not just about spotting damage. It's really about grasping how a problem in one tiny spot can ripple outwards, how it can affect our thoughts, our senses, our movements in really profound ways. Getting that location right is so crucial for treatment. And like you said, it really deepens our appreciation for the sheer intricacy of it all.
Okay, let's unpack this then, right from the beginning. We're talking about two main categories of brain injury here. Cortical lesions and subcortical lesions.
Yeah.
So what's the basic difference? Where's the dividing line?
Well, fundamentally, it comes down to location, anatomy. Cortical lesions, these are injuries to the cerebral cortex itself. That's the wrinkly outer layer of the brain, the part we often think of as handling higher thought processes, your thinking cap, so to speak. And these lesions are tied directly to what we call cortical signs and symptoms. And these are things impacting higher order functions like aphasia, that's language problems, homonymous synapsia, a specific kind of visual field loss, agnosia, trouble recognizing things even if your senses are working, and neglect, where someone might seem unaware of one side of their body or their surroundings.
Okay, so that's the cortex, the outer layer.
Right. Then you have subcortical lesions. These are injuries deeper inside the brain beneath the cortex. We're talking about structures like the basal ganglia, the thalamus, the internal capsule, really crucial relay stations and control centers deep within the cerebral hemispheres. And the symptoms, they tend to be quite different. Often things like motor problems, weakness, maybe involuntary movements, or sensory loss. And sometimes cognitive or behavioral changes too, but typically without those specific cortical signs we just mentioned, like aphasia or neglect.
Got it. So before we even get to figuring out which type of lesion it is, if someone comes in and we suspect a brain issue, there's a really critical first step, right? Especially if they're unstable.
Oh, absolutely. Patient stability is paramount. If someone is unstable, it's an emergency. Forget localization for a moment. The focus immediately shifts to the ABCDE assessment: airway, breathing, circulation. Stabilize those vital functions first. That might mean intubation, ventilation, getting IV access, maybe fluids, definitely continuous monitoring heart rate, blood pressure, oxygen levels, cardiac rhythm. And if there's high pressure inside the skull, intracranial pressure, managing that is a top priority. That comes before anything else.
Right. First things first, stabilize the patient. But once they are stable, then the detective work begins. We move to a more focused history and physical exam. What kind of things might a patient or maybe their family report that make us start thinking, could this be a cortical or subcortical lesion?
Exactly. For a stable patient, the history is key. They might report trouble speaking or understanding speech, or sudden vision changes, maybe weakness or numbness down one side, or sometimes more subtle things like changes in thinking, behavior, difficulty identifying everyday objects. Then the physical exam helps confirm or refine those suspicions. We're looking carefully for any cognitive impairment, any unusual behavior, and we specifically test for those cortical signs: agnosia, aphasia, neglect, any visual field deficits. Plus, of course, checking for weakness and sensory loss. An important point here for the lesions we're discussing today, these cortical or subcortical ones, you generally don't see that specific pattern of, say, facial weakness on one side and limb weakness on the opposite side. That particular crossover pattern usually points more towards the brainstem. Here, the effects are often one-sided, but without that specific contralateral face-limb split.
Okay, that's a helpful distinction. So after that initial assessment, the history, the exam, here's the big question, really, for everyone listening and for clinicians. How do you actually tell the difference? How do you decide if it's cortical or subcortical? What's the fork in the road?
It really boils down to the presence or absence of those specific cortical signs and symptoms we listed. If your examination reveals clear signs of aphasia or homonymous synopsia or agnosia or neglect, then you can be pretty confident you're dealing with a cortical lesion. Those are the big flags. But if those specific signs aren't there, then your focus shifts. You start looking for evidence pointing towards those deeper subcortical structures. It's a really fundamental decision point in figuring out where the problem lies.
Okay, that makes sense. A clear dividing line based on those specific cortical signs. So with that foundation, let's dive into those cortical clues. This is where it gets really interesting, I think. Because once you suspect it's cortical, the type of symptom can point to an incredibly specific spot on that brain map. Let's start with language. Aphasia. You mentioned it's language impairment, but there are different kinds, right?
Absolutely. And the type of aphasia is incredibly informative. Let's take Broca aphasia, sometimes called expressive aphasia. Patients with Broca's really struggle to get words out. Their speech is non-fluent, halting, it takes a lot of effort. Writing is usually impaired too, and repeating phrases is difficult. But, and this is the key, their understanding, their language comprehension is largely intact. They know what you're saying, they just can't easily express their own thoughts.
Yeah.
When you see that pattern, it points strongly to a lesion in the left posterior inferior frontal lobe, Broca's area, vital for producing speech.
Okay, struggles to speak but understands.
Right. Now compare that to Wernicke aphasia. It's almost the reverse situation. These patients often speak fluently, sometimes excessively, but the speech doesn't make sense. It can be like a word salad, just jumbled words and phrases. They often use paraphasic errors, substituting words that sound similar or are related in meaning but are incorrect in context. Repetition is poor, and crucially, their language comprehension is significantly impaired. They have great difficulty understanding spoken language. This pattern points to a lesion in the left posterior superior temporal lobe, Wernicke's area. Discovering these distinct areas, Broca's and Wernicke's, was, well, revolutionary. It showed us how the brain breaks down something as complex as language into different components, production versus comprehension. They're linked, of course, but handled by different zones.
It's amazing, that separation of function. Fluent but nonsensical versus non-fluent but understanding. Okay, let's move from language to vision. You mentioned homonymous synopsia, visual field loss on the same side in both eyes. What specific patterns here help us localize?
Right. With homonymous synopsia, the exact pattern of vision loss is the clue. For instance, if someone has a right superior quadrantanopia, that means they've lost vision in the upper right quadrant of both eyes. That strongly suggests a lesion affecting the inferior optic radiations. These are nerve fibers that loop down through the left temporal lobe on their way to the visual cortex. It's like a specific pathway being interrupted.
So a quarter field defect points to that specific loop of fibers.
Exactly. And a little clinical pearl here. Sometimes a lesion just above or just below a key landmark in the occipital lobe called the calcarine fissure can also cause a contralateral quadrantanopia, so affecting just one quadrant. Then there's right hemianopsia with macular sparing. This is loss of the entire right half of the visual field in both eyes, except for the very center of vision, the macula. That part is spared. This pattern is really characteristic of a lesion in the left occipital lobe, often due to a stroke affecting the posterior cerebral artery. And the reason for the macular sparing is fascinating. It's because the very back tip of the occipital lobe, the occipital pole, which processes central vision, actually gets blood supply from both the posterior cerebral artery and the middle cerebral artery. So even if one is blocked, the other can often keep that central spot working. Dual supply saves the center.
That's a neat anatomical reason. So the macula gets backup power, essentially.
You could think of it that way, yeah. It's also worth mentioning that sometimes lesions in the optic tract or a structure called the lateral geniculate nucleus can cause homonymous hemianopsia too. But typically, the visual field defect isn't quite as perfectly matched or congruous between the two eyes as it is with an occipital lobe lesion. The occipital lesions tend to produce very symmetrical defects.
Okay.
And this brings us to a really intriguing phenomenon called a disconnection syndrome. It's called alexia without agraphia. Alexia means inability to read. Agraphia means inability to write. So these patients cannot read, but they can still write perfectly fine.
Wait, they can write but can't read what they just wrote.
Exactly. It sounds bizarre, right? It's caused by a very specific lesion, usually in the left occipital lobe, that also damages a part of the corpus callosum called the splenium. The corpus callosum is the big bridge connecting the two brain hemispheres. The splenium is the back part of that bridge. So what happens is this. The left occipital lesion knocks out the right visual field. Okay, that's standard. But the patient can still see in their left visual field. That information goes to the right occipital lobe. Normally, that visual info would cross over the splenium to the language areas in the left hemisphere, which handle reading. But if the splenium is damaged, that information can't cross. So the visual information from the intact left visual field never reaches the reading center in the left hemisphere. They can see the words with their right brain, but can't process them for reading with their left brain. Writing originates in the left hemisphere language areas, so that's usually okay. It's a pure disconnection.
Wow. That really highlights how interconnected everything has to be. A broken bridge leads to such a specific, strange deficit. Okay, moving on to another fascinating cortical sign. Agnosia. You define this as being unable to recognize things, objects, people, sounds, even though the basic sensory ability, like seeing or hearing, is intact. Can you give us some examples? What forms does agnosia take?
Sure. A classic example is something called Gerstmann syndrome. It's a very specific cluster of 4 deficits. It includes acalculia, which is the inability to do math calculations, agraphia, inability to write, like we just discussed, but in a different context here, left-right disorientation, trouble telling left from right, and finger agnosia, which is the inability to identify individual fingers, either on your own hand or someone else's. When you see that specific quartet of symptoms, it points pretty reliably to a lesion in the left angular gyrus, which is tucked away in the posterior part of the inferior parietal lobe.
A very specific set of symptoms linked to one small area.
Precisely. And then there's prosopagnosia, which most people know as face blindness. Individuals with prosopagnosia can see a face perfectly clearly. They know it's a face. They can describe the features. But they just cannot recognize who it belongs to. Even faces of people they know extremely well, like family or close friends. This is typically associated with damage to the fusiform gyri, usually on both sides, located in the inferior occipitotemporal cortex. That's kind of where the visual processing streams for what an object is are located.
That must be incredibly difficult socially and emotionally, not recognizing loved ones. Have you seen how people cope with that?
It's profoundly challenging, but people are remarkably adaptive. Patients often develop strategies. They learn to recognize people by their voice, their walk, maybe a distinctive hairstyle or glasses, or the clothes they usually wear. It really forces them to rely on other cues. It definitely underscores the huge impact of losing that specific recognition ability, but also, yeah, the brain's capacity to find workarounds.
A testament to resilience. Okay, one more cortical sign to cover. Neglect. This sounds really counterintuitive, where a patient seems to ignore one side of their world. How does that actually manifest?
Neglect is truly fascinating, and it can show up in several ways. You might have a patient who has weakness on one side hemiparesis, but they seem completely unconcerned about it, almost indifferent, or they might even deny that the weak arm or leg belongs to them. Then there's spatial neglect. This is where they ignore stimuli on one side of space. If you ask them to draw a clock, they might cram all the numbers onto the right side and leave the left side completely blank. Or if you show them a picture, they might only describe what's happening on the right half. Another common test is for sensory extinction or extinction to double simultaneous stimulation. You touch the patient on both arms at the same time. They can feel a touch on either arm individually, perfectly fine. But when you touch both simultaneously, they only report feeling the touch on one side, typically the right side. The sensation on the neglected side is extinguished. All these findings, the indifference, the spatial ignoring, the sensory extinction, point strongly towards a lesion in the right parietal lobe. The right parietal lobe seems to be especially critical for spatial awareness and attention, particularly concerning the left side of space and the body.
Wow. Ignoring half the universe, essentially. It really drives home how much our perception of reality is constructed by the brain. Okay, now let's switch gears. We've covered the cortex and its clear signs. But what happens when those signs, aphasia, anopsia, agnosia, neglect, are absent? Yet the patient clearly has neurological issues. That's when we start thinking subcortical, right? So how do we localize these deeper lesions? Let's start with motor symptoms, which you said are common.
Right. If those classic cortical signs are missing, we look deeper. If the main finding is isolated unilateral hemiparesis weakness on one side, and it affects the face, arm, and leg pretty much equally, that's a strong clue. It points quite specifically to a lesion in the posterior limb of the internal capsule. This is a superhighway for motor fibers deep in the brain. A small lesion there can cause widespread, equal weakness.
So equal weakness is the key for that spot.
Generally, yes. Now, a little nuance. Sometimes a lesion in the corona radiata, the fibers fanning out just above the internal capsule, can also cause hemiparesis. But usually, it's not as likely to affect the face, arm, and leg quite so equally. There might be more pronounced weakness in the arm than the leg, or vice versa, so that pattern difference can be helpful.
Okay. What about other kinds of motor symptoms, more dramatic ones?
Yes, if the motor symptoms aren't just weakness, but rather abnormal involuntary movements, what we call hyperkinetic movements, like hemiballismus, these are wild, uncontrolled flinging movements, usually just on one side of the body. Or chorea, these look more like dance-like, jerky, irregular movements. If you see those kinds of involuntary movements, you should suspect a basal ganglia lesion. The basal ganglia are crucial for regulating movement, and damage there can release these abnormal patterns. And specifically with chorea, it's important to consider and often rule out conditions like Huntington disease, which famously involves degeneration of the basal ganglia, especially a part called the caudate nucleus.
So involuntary movements point to the basal ganglia.
Primarily, yes. And here's a high-yield point. A lesion in a nearby structure, called the subthalamic nucleus, can also disrupt basal ganglia circuits. Damage here often leads to contralateral hemiballismus, those wild flinging movements on the opposite side of the body. It happens because the subthalamic nucleus normally helps inhibit unwanted movements via the thalamus, so damaging it removes that inhibition.
Fascinating how a small, deep structure can unleash such dramatic movements.
Yeah.
Okay, moving from motor to sensory. What if the main issue is sensory loss?
If the exam reveals hemisensory loss, meaning loss of sensation affecting the face, arm, and leg, all on one side, the most likely location for the lesion is the thalamus. The thalamus acts like the main relay station for almost all sensory information heading up to the cortex. So a lesion there can cause widespread sensory deficits on the opposite side of the body.
Thalamus is the sensory gateway.
Yeah, got it.
And finally, what about those deeper structures that influence our thinking, emotions, behavior? If those are the primary changes, where do we look?
Right. For prominent cognitive or behavioral changes without cortical signs, we often look to structures in the medial temporal lobe. Two key players there. First, the amygdala. This is heavily involved in processing emotions, especially things like fear, anxiety, and also basic drives. And second, the hippocampus, which is absolutely critical for forming and storing new memories.
Okay, amygdala for emotions, hippocampus for memory. How do lesions there present?
Well, a really striking, though rare, condition linked to amygdala damage is Kluver-Bucy syndrome. This usually requires bilateral amygdala lesions. Patients develop a very unusual set of symptoms. Hyperphagia, meaning they eat excessively. Hyperorality, a tendency to put all sorts of objects, even inedible ones, into their mouth. Hypersexuality, and often a strange placidity or apathy, a lack of normal emotional response. It really highlights the amygdala's role in regulating these fundamental drives and emotional behaviors.
That's quite a collection of symptoms. And the hippocampus.
If the most prominent symptom is memory loss, particularly difficulty forming new memories, forgetting recent conversations, events, where they put things, performing poorly on tests of delayed recall, then the hippocampus is the prime suspect. Damage here disrupts that crucial process of memory consolidation.
Okay, so let's try to tie this all together. We've gone through cortical signs, subcortical signs, specific locations. For someone listening, what's the takeaway? If you suspect a brain lesion, what's the thinking process, the algorithm?
It really comes down to a systematic approach. First, you actively look for those key cortical signs. Is there aphasia? Is there homonymous anopsia? Is there agnosia? Is there neglect? If the answer is yes to any of those, you're likely dealing with a cortical lesion. Then, the specific cortical sign that's most prominent helps you narrow down the location within the cortex, just like we discussed Broca's area for expressive aphasia, right parietal for neglect, and so on. If, however, the answer is none of those specific cortical signs are present, then you shift your focus to subcortical structures, and you localize there based on the dominant pattern. Is it isolated, equal hemiparesis pointing to the internal capsule? Is it involuntary movement suggesting the basal ganglia? Is it hemisensory loss pointing to the thalamus? Or is it primarily memory loss or specific behavioral changes pointing to the hippocampus or amygdala?
It really is like neurological detective work, isn't it?
Yeah.
Following the clues step by step.
It truly is. There's an incredible amount of precision involved. Each symptom offers a potential window into the function of a very specific brain area. It really highlights not only the specialization within the brain, but also how interconnected everything must be for it all to work seamlessly.
And I think that's why understanding this is so valuable, even if you're not a neurologist. It just gives you such a profound appreciation for the brain's complexity, how incredibly intricate it is, how specific damage can lead to specific, sometimes bizarre, changes, and the careful process involved in diagnosis, it makes you really appreciate your own working brain. So here's something to maybe mull over after listening. Think about how a subtle change, a tiny lesion in just the right spot, can fundamentally alter how someone perceives reality, or access their memories, or even recognize the face of someone they love. It makes you wonder, what other everyday human experiences, things we take completely for granted, might rely on such incredibly precise, yet potentially vulnerable circuits deep within our brains? What else is waiting to be understood? Thank you so much for joining us on this deep dive into the brain's blueprint. Keep exploring, keep asking questions. We'll catch you on the next one.